Hello, good afternoon, everyone. Thank you for joining us today. Can you hear us? Can you raise your hand or tell us if you can hear us?
Yes.
Okay, thank you. Thanks for joining us today. Today we have a very special guest, Dr. Lesley. She is a clinical oncology consultant in Leicester Royal Infirmary Hospital. And we are very pleased to have our panel members today, Dan, Simon, Dr. Kashif, and Sophia, who will contribute their expertise in radiography, physics, and dosimetry. So we have a complex case today about paraspinal mass re-irradiation. So hopefully we'll have interesting case, amazing discussion as usual by our panel members. And please feel free to raise questions if you will do things differently. This is our chance to contribute and exchange our experience. So now I will leave the panel to Dr. Speed. At the end, we would appreciate if you could fill in the evaluation form. This helps us to improve the forum and to guide the sessions forward. So now I will share Dr. Speed's presentation and I will give her the mic.
Okay, thanks everyone for joining. So I'm going to go through a short case study of a patient of mine for whom we considered re-irradiation. So we'll just go through the clinical scenario, different treatment options through his journey. We'll talk a little bit about some radiobiology, what we need to consider and how calculations are done. And then ultimately what we did do for this patient. So this is a 63-year-old man who was originally diagnosed with a liposarcoma in his buttock back in 2018. This was non-metastatic, and so he received preoperative radiotherapy, 50 gray and 25 fractions to his buttock, and then he had resection. So sarcoma patients get regular clinical and radiological follow-up, and several years later he had an abnormal chest x-ray during surveillance. So he was completely asymptomatic at this point, but his chest x-ray showed this. Use a mouse. So he's got what looks like a soft tissue density mass in his kind of right upper zone. So he went on to have a CT scan to assess this further, and hopefully you can see that this shows at this point, and it's an approximate 4 by 3 centimetre axial soft tissue mass, and it measures about 5 centimetres superiorly and inferiorly. What you can't appreciate on those single slices is that there was also extension into the spinal canal, particularly around the T4-5 area, and he also had a bony deposit within T5 and T7. So all near each other, all localised, but bony and soft tissue disease. He had a biopsy which confirmed this was metastatic liposarcoma. Staging didn't show disease anywhere else. And so at this point he was offered high-dose palliative radiotherapy. It wasn't felt to be resectable because of its extension into the spinal canal, so he had radiotherapy. So at this point he received 45 gray and 25 fractions to all of the soft tissue disease, but also encompassing the T5 and T7 lesions. It is a little bit tricky, I appreciate, to see perhaps the lines on here, but you can see obviously the soft tissue mass, and then around this there is a PTV line which extends across the vertebra, because we need to encompass that for our treatment volume. And that PTV completely covers the spinal canal. There is a second line on there, if you can see at all, there's a green line, which is the 95% isodose. So essentially our spinal canal is getting all of that dose. The other images show that we're also encompassing the vertebral bodies within that PTV as well. We did prescribe 45 gray and 25 fractions. The maximum cord dose, in fact, was 46.9 at this point. Perhaps this zoomed in image shows you a little bit better. The red is the PTV line and the green is the 95% isodose. So that is all encompassing the spinal cord. So this was back in 2020. He continued surveillance, but a couple of years later developed an increase in the paravertebral mass. Unfortunately, at this point also developed liver metastases and also further bony mets within T10 and a more extensive lesion within the lower lumbar vertebra. Again, this also had soft tissue which extended into the neural foramen. So he received some palliative radiotherapy to his lumbosacral spine with a direct posterior field. He then had some palliative radiotherapy to his thoracic spine, again a posterior field. And because of the extent of his disease at this point, he then commenced palliative chemotherapy. So he completed 6 cycles of doxorubicin with a partial response in the paravertebral soft tissue mass and his liver metastases. So for almost a year he was well, and he had surveillance imaging which showed no further progression of any of his disease until December 2023, so 11 months after he completed his chemotherapy. At this point the paravertebral mass increased in size again. He was becoming a little bit more symptomatic with pain at this point, and he commenced second-line chemotherapy. Unfortunately, this didn't really help, and on his interval imaging, the mass had grown further. It's now up to 8 centimetres, and he'd also developed a lesion on the opposite side. So at this point, he changed systemic therapy again, and he commenced trabectedin. So for this chemotherapy, if you're not familiar, there isn't a maximum number of cycles, and you continue until progression, or a patient can't tolerate it in terms of toxicities. So he had trabectedin continuously throughout 2024. Imaging in November showed he had stable disease in all of his areas of metastases. But by February, his mass had progressed again. It's now up to 11 centimetres in a craniocaudal direction, but he had stable disease elsewhere. So his liver was stable, there were no new bone mets, his known about bone mets were stable, and the pleural lesion that we discovered in the other lung was also stable. But he was more symptomatic with neuropathic pain coming from this upper thoracic mass. So this image just shows at the time of progression in February. You can appreciate on the previous imaging it was obviously a much smaller kind of 4 by 3 centimetre mass. This is bigger now in all dimensions. So it's 11 centimetres craniocaudal, and it was about 8 to 9 centimetres medial to lateral. So at this point we thought, well, what can we do now? So he's progressing in one place, the rest of his disease is stable. So should we change chemotherapies? But anybody who knows anything about sarcoma treatment is that we actually have very limited chemotherapy options. He's already on 3rd line. He's now 69. Whilst he remains fit and relatively well from a performance status point of view and comorbidities, we are limited in other systemic options. Should we just stop everything actually altogether and say that he's for best supportive care and symptom management? He didn't like this idea. We didn't really like this idea either. It didn't feel the right thing to do. He's still keen for treatment and does remain quite fit. So should we consider re-irradiation? The spinal mass is the only area that is progressing. So re-irradiation is defined as an additional course of radiation which at least partially irradiates the same tissue as a prior course with a biologically meaningful dose. So that as opposed to repeat radiation, which is where you would treat a different area of the body. But it's also interesting that the definition encompasses a biologically meaningful dose. Because if you're not giving a biologically meaningful dose, what are you trying to achieve? But also then you don't really need to worry about the fact that you're re-irradiating it. So what do we need to think about if we're going to re-irradiate a patient? We need to think about the site. So what area of the body are we at? What kind of tissue are we re-irradiating? Is it a radioresistant? Is it radiosensitive tissue? Obviously, what dose have they had before? And importantly, do you actually confidently know what dose they've had before? So a lot of us will inherit patients that have been treated elsewhere previously for their disease. You know, they might move into your area and they say, oh yes, I had 4 weeks, 5 weeks of radiotherapy 3 years ago in another centre. So unless you can actually get hold of that plan and know confidently what dose they've had, then re-irradiation might be a little bit difficult. You need to also think about the time interval. So when did they have treatment? So if it was only 2 months ago, then you need to think about the possibility of re-irradiation. Have you got scope to do that? But actually, is it going to work? Because if it didn't work 2 months ago, you're perhaps not going to get much of an improvement now. Along with the site, you need to think about other organs at risk in that area and the tolerance of all of those to be able to safely treat them. And have they had other radiotherapy treatment? So they might have had other repeat radiotherapy, but not re-irradiation. But where was that? And do you need to consider that as well? And of course, what toxicities did they get from their previous treatment? If they had significant toxicities with their first course of radiotherapy, it might not be appropriate. So you might be able to treat them clinically, but actually you might make them worse, not better. And again, as the definition said, you need to make sure that you can give them a meaningful dose. So, you know, if you've only got scope to give them perhaps 4 or 5 gray because of your tolerances of your organs, then that might be all right. If you're treating a lymphoma, it might help a little bit, but for most of the tumours, it's not going to be. So you need to make sure that the dose you can deliver is actually going to have the outcome that you desire. So I will pass over to Sophia, who will go through the considerations that we had for this case in terms of the radiobiology. Let's just check she's logged in.
Sophia, can you hear us? We can't hear you.
Bear with us a second.
So just a moment. We are waiting for Sophia. I think she might be trying the old link. So she's joining us from. Hi Sophia, how are you?
Hello.
Hello, I'm good, thank you.
Hi.
Apologies for this.
That's fine.
Some
Sorry.
confusion with the links.
We've just gone through the background to the case, and we are up to the point of discussing, can we re-irradiate this chap and what do we need to reconsider?
Sure. This gentleman had 3 previous treatments, one in the thorax in January 21, one in the L spine, as you can see in the second column, and one in September 2022 in the T spine, T9 to 11. So the question here, and he came back to us recently, and the question is what dose we can deliver that it's meaningful but also safe. So first of all, we need to see the location, and we need to identify the organs at risk that we need to take into account in the radiobiology, in our radiobiology calculations. So you can see the current treatment is at the same level roughly as the first treatment was in January 2021. So one of the critical organs is the spinal cord. This happened in discussion with the doctor as well. So we decided that spine and lung are the critical structures here, and these the 2 organs that we did the radiobiology for. So but for spine, for example, what's important is the maximum dose to the spine. So, however, for the lung, it's more the volume effect is more prominent. So, therefore, we approached the 2 organs differently. So, for the spine, we only took into account the first treatment in 2021 in the thorax because that was the same part of the spine. So, and we ignored the spine dose from the second and the third treatment. So for the spinal cord, we have a form that was developed locally. We took the tolerances for the cord from Quantec. So for the 6% risk of myelopathy, Quantec says that the tolerance is 60 gray in EQD2, while for 0.2% risk of myelopathy, then the tolerance is 50 gray in EQD2 as well. The alpha-beta ratio that we use for spine, again, was taken from Quantec. Is 2, and we recorded the dose received from the first fraction in 2021. So the number of fractions was 25. Back then it was 45 grain, 25 fractions. So we calculated the EQD2. The form calculates the EQD2 from that first treatment, and then we can assume some recovery. So we can assume either 0 recovery. That's a strict approach, as the patient had the first treatment 4 years ago. So at 25% also recovery seems sensible after 4 years for the cord. So we take into account the recovery in our calculations. So the form calculates the remaining dose in EQD2 for the second fraction. So that remaining dose in EQD2, then it will be converted in the maximum dose allowed in the new plan, taking into account the number of fractions of the new plan. So the 14.6 EQD means it's the tolerance for 5 fractions is 12.8 for 6% myelopathy with no recovery assumed, or 13.5% for 0.2% myelopathy with 25% recovery assumed. So we give those values to the planner, and they try to produce a plan by using those values. Now for the lung tolerances, if you go to the next slide. Thank you. So for the lung tolerances, if you remember the first slide, the T9 to 11 spine plan included some of the lung as well. It was different part of the lung, but still it's an organ that the volume that it's radiated matters rather than the point dose. Therefore, we decided to take both plans, so the thorax plan and the T9 to 11 plan lung doses into account for the calculations. Therefore, you can see, so top and bottom table are the same tables, but top table, no recovery is assumed, while in the bottom table, 25% recovery assumed. The tolerances are exactly the same, so we took the V20 gray less than 30% tolerance from Quantec for 20% risk of symptomatic pneumonitis, and we got D mean and V20 gray from our local protocols for radiotherapy to lung with 60 gray in 30 fractions, and we convert them to EQD dose. So because this form is developed to take into account only one previous treatment, but in that case, we have lung doses from 2 previous treatments. So we calculated the EQD to the lung for each of these metrics separately by hand, and then we added them. So we have an EQD, a sum EQD from the 2 previous treatments, which is 9.4 gray for D30%, 8.6 for the mean dose, and 7.8 for the D35%. Again, with the remaining dose was calculated by the form, and it was converted to the 5 fraction equivalent, which was given to the planners again as a tolerance. So for the 0% recovery was given as optimal constraint, while the 25% recovery was given as a mandatory constraint. So next slide. So once the plan was ready, then the planner notified the physicists who did the radiobiology, and the new plan values were added to the forms, and we have a total EQD tolerance, and then a total EQD achieved from all treatments. And as you could see in the tables below, before, they were all within tolerance. But to achieve the spine tolerance, for example, we had to compromise part of the spine. Also, in terms of prescription, based on the OAR tolerances, it seems like 20 gray in 5 fractions would be achievable, which is a meaningful palliative dose to the patient. And this was achieved by compromising part of the cord. I believe there are some slides after this to show this. The EQD, the total EQD was intolerance for lung and spine. One thing to be mindful of when you do radiobiology calculations is the uncertainties that involved in those calculations, as there is great sources of uncertainty, and have included some sources such as the fusion, the deformation of the planning CT, positioning, patient positioning and anatomy. There might be different between the treatments, contouring uncertainty, alpha beta values, and the assuming recovery data from Quantec. They also have a certain degree of uncertainty, so be mindful of that as well. That's it from me. Back to you.
Okay. So you touched a little bit on sort of the sources that we use to try and work out our radiobiological calculations. Quantec is obviously the sort of main source, if you like, of working out tolerances to different tissues, different organs. And they do sort of state that you get partial repair of subclinical damage starting to happen about 6 months after radiotherapy. There's an assumption that that continues, but it's a little bit more difficult to quantify by how much over what time period. The other sources that we can use, there is an RCR document about the principles of re-irradiation. That's quite helpful if you're thinking about treating somebody again. There are several publications in both the red and green journal that are looking at re-irradiation of different tissues. I think the commonest sites for re-irradiation are often head and neck, pelvis, and then bone metastases. There was a survey done by Estro a little while ago that's asked multiple clinicians across multiple countries about how they approach re-irradiation, and unsurprisingly there was a wide variety of answers and thoughts on sort of tolerances and what risk people would take, but that also highlighted that there is sort of a paucity of guidelines really, so there aren't any real hard helpful guidelines on what you should be trying to achieve, or how much repair, for example, you can be confident in at a certain time point after the original treatment. Sometimes it's useful to look at SABR guidelines for certain parts of the body. SABR obviously has been used a lot for re-irradiation, for solid tumor metastases, so they are often another source that we can use to help us make a decision if it's safe to re-irradiate. So what we actually did for this man, again I'm hoping it might be projecting, so you can see his soft tissue mass here, and this is outlined in red, so this is our soft tissue GTV. On top of that we have overlain the original PTV, so this pink line is the original PTV from 4 years prior to now. The PTV originally encompassed the vertebra, if you can remember. So the current plan, we weren't deliberately going to include the vertebra. We just wanted to focus on the soft tissue mass. The outer red line, it's a little bit more tricky to see, is our ideal PTV with a margin around our GTV, and this covers half of our spinal canal. So we were talking earlier about what tolerance we have left for our spine in particular, and that was around about 13 Gray. If we were, however, trying to give 20 and 5, that's not really going to be safe and achievable if our PTV covers half of our spinal canal. We aren't going to be able to give 20 Gray. So what we decided to do is to crop the PTV in this area, and we took it back by about 1 centimetre around the spinal canal. So the turquoise line is where we've cropped the PTV to. In the other directions we didn't crop anything at all, but we're just concentrating on this spinal canal area, so to try and deliver 20 Gray and 5 fractions to the actual soft tissue mass, but we accept we can't give that medially because we're going to compromise the cord if we do that. It might be a little bit easier to see on this window. So the red is our original PTV, which covers our spinal cord. And then this is our cropped PTV. So we're still got all of our soft tissue mass within that, and we're just altering the volume at this corner. Ultimately, this was treated with a plan of a partial arc. Soft tissue mass in the middle. Our orange line is now our PTV and the 95% isodose line is our green line, which is nicely covering that whole PTV area. In terms of the spinal cord, the pink line here is 13 Gray, which was our calculated tolerance, or what we had left, if you like, potentially for the cord to receive. So the edge of the cord is just receiving that 13 Gray, but more of it is actually receiving a smaller dose to that. The lower graph just shows the DVH for the cropped PTV and the spinal cord, and the maximum dose to the spinal cord ended up being 11 Gray. So we were within our additional tolerance allowed for the spinal cord. So he tolerated the treatment well. He did get an improvement in the neuropathic pain that he had. He has continued with his trabectedin because the rest of his systemic disease was being controlled. And he's had a further CT scan post-radiotherapy, which shows stable disease. So we know the soft tissue paraspinal mass was increasing in size and had gone from about 9 to 11 centimetres from November to February, and is now stable. So hopefully suggesting that the radiotherapy has had an effect. You do sometimes see also a more delayed response for the liposarcomas, and he did have a delayed response when we treated him initially in 2021. So hopefully in his subsequent imaging, the paraspinal mass is at least stable or may have even shrunk at that point. So really just to summarise the case and what we've been discussing, you need to consider re-irradiation. It may be appropriate in a situation for limited disease or if you have a solitary site of progression and there's a reasonable time frame from their previous treatments. You need to think about the dose received to that area of the body and all the adjacent organs at risk. And do you know accurately what doses they did receive? So as I say, you need to have as much information as possible about all their previous treatments. We need to consider what meaningful dose we can give to re-irradiate. So what type of tissue is it? What kind of tumour are you trying to treat? Are there any alternatives? So whilst re-irradiation might be possible, is it the best thing for the patient? So we need to think about other systemic options or the other perhaps modalities for treatment. For a small number of people, it might be reasonable to consider actually re-irradiation with protons, not necessarily a standard photon plan. We need to think about the consequences of not treating. So often when we think about critical sites such as a spine, yes, we are absolutely concerned about the dose that our spinal cord receives because of the potential for myelopathy. But if you have a rapidly growing tumour, that potentially is going to damage your cord anyway. You need to think about that risk benefit balance. And the patient needs to be adequately consented. So they need to understand that this is a retreatment that potentially goes up to or occasionally maybe slightly over what you'd want to give them in an ideal world from a tolerance point of view of organs at risk. And the patient needs to be involved in that discussion. And that's it. Welcome any questions. Thank you.
Thank you, Dr. Speed, for this amazing talk. Any input from our colleagues on the chat? If you have any questions, if you do things different in your center? Any input from the panel members? Any contribution or any advice about re-irradiation?
Hi, can I ask a quick question? So you know the when you have a critical OAR such as the spinal cord, and you're really being careful that you don't escalate the dose up to beyond the tolerance. Would you mark that out with a PRV as well, so allow a bit of gap beyond the kind of marked up cord, and just
Yes.
to allow for motion? Yeah. Okay. So that would be your cut-off point.
there was on the final plan there was a PRV around the spinal cord.
Great.
So, Kashiv, we have a PRV around the organ itself,
Yeah.
to make sure that's okay, but we also cropped 5 mil from that PRV, just to be 100% certain it wasn't a problem.
Okay. Being super safe.
Yeah.
And I think
And
also
one other question.
I think also
Sorry,
the
I'll
thing
just-
we did here is about defining our maximum dose that the spinal cord can tolerate, and we draw this line, so we make sure that we are not overseeding this particular dose to the spine. This was a good trick as well that was done in this case. So we have a question in the chat.
So about using the 25% recovery, and you would normally assume 50% recovery. So it is a good question. It is difficult to find a lot of evidence to know beyond sort of 6 months, 12 months, how much recovery there is. There is data suggesting after 6 months you get about, as you say, 25%. I think we were erring on the side of caution, particularly because it was a spine. I don't know if Sophia has other thoughts about. I mean, to me, it feels like, yes, you would get more recovery over time, but I think because it's difficult to quantify that and be sure, that's
So
why we
our
didn't go for higher.
calculations are very conservative. First, because we assume a recovery of 25, which I agree it's probably low after 4 years. But also we also assume that the maximum dose is always at the same part of the cord based on the calculations. The only way to review that is by reviewing both treatments next to each other. So the other thing for the cord, there is guidance in general for cord in particular that we shouldn't use more than 50% recovery. So yeah, 50% recovery for the cord should be the limit really.
Yeah, and I think also the type of tissue we are dealing with will play a factor. If we are dealing with late reacting tissue like spinal cord with delayed recovery, I think we should be more conservative. But you're dealing with rapidly proliferating tissue that can have higher rates of repair, then I think we might be more generous with the recovery factor.
Mm-hmm.
The problem
Yeah,
is,
there are organs like I think kidneys that they don't never recover from radiation, and there are organs that are recovered well. So it shouldn't be like a general rule. It should be like look into each individual organ.
Yeah.
Sophia, just generally, have you come across much other published data about recovery factors for other tissue types? Because I found it very difficult for anyone to pinpoint a percentage recovery.
I think for the cord there are many publications.
Cord seems to be the best.
Cord seems to be the best.
Yeah.
I agree, but no, it's not. There isn't a consensus on that, I believe. That's why we go conservative.
Yeah.
I mean, another question that I would like to ask is whether the life expectancy of the patient plays any role, because all those late effects have a time of manifestation of 6 months, the earliest to 2 years probably for the cord myelopathy. Would that be a factor as well to consider in the decision?
Yeah. So obviously, if somebody has a good prognosis, we are going to be more concerned about the potential risk of myelopathy and other toxicities. So this gentleman in particular, although he is on third-line chemo and he does have mets in other places, he has relatively slow-growing disease. So I think his prognosis would still be in the order of a year or more. So we did need to take that into consideration.
Mm-hmm.
Anyone has any further contribution, any further question? In this case,
Thank you very much.
Thank you, Dr. Zbeed. Thanks to the panel. Thanks, Sophia, Kashif, Simon,
Thank you.
and Dan. And thanks for Sagar, our coordinator for the forum. We would appreciate if you can fill in the form. We really would be guided by your feedback. So it would be really appreciated if you told us what you thought about the session today, how we can improve our forum, and how we can take it forward. And also we are waiting for your contribution. If you have any interesting case, if you would like to be a panel member, if you are a senior colleague, please feel free to contact me or to fill in the relevant forms. So we have, I think we have attached the evaluation link in the chat group. If you can, please fill in the form, and see you next month. Thank you so much.
Thank you.
Thank you. Bye.
Thank you.